Hi, everybody. This is Susan Clinton, and welcome to Tough to Treat. In this episode today, we're going to be talking about our person that we talked about in an earlier podcast who injured herself on her boat. And we're looking at the updates and kind of what's gotten better and what's changed. And this podcast is really focusing on hip arthritis and getting people to move in novel and rich ways that the longstanding problem has really prevented them from doing. We hope you like the podcast. We look forward to your responses. Thank you. Hi, everybody. This is Susan Clinton, and I'm here with Erica Mello, and we are Tough to Treat. And hi, Erica. How are you today?
I'm good, Susan. And yourself?
I'm doing well. Thank you. So, today I wanted to talk a little bit about hip arthritis, if possible.
So I've run
into various clients, and I think you guys all know this who have listened to us before. We've talked about anterior hip pain and anterior hip sensitivity, and those types of things. Do you mess with the labral tear? Do you not mess with the labral tear? But this particular person is somebody that we've talked about, and I can't remember the number of the podcast, but it was the lady who was on the sailboat that had the accident.
Oh, yes.
Stepped through the hole.
Yep.
And, the hole in the hull. And she had been doing really well. Back stuff all finally cleared up, and the pelvic stuff cleared up. But what she's into, I had the ability to see her over the holidays, and she came in for a eval, and a couple of treatment sessions. So I had an opportunity to see her before they left to head back to their boat. So, the biggest issue with her is, as she kind of walked in the door is, you could tell that so it's her right hip. Just to give you the background again, 64-year-old female, lives on a sailboat with her husband, and, had the injury where she stepped through an open hatch in the hull of the boat. Without warning, so she fell pretty hard.
Yes, Susan, sorry to interrupt.
Sure.
Podcast 37 was when we
podcast 37.
Talk about that. Yep.
And if you want to go back and re-listen to podcast 37, you can hear the history and what we did. The issue that I was working with her mostly on, she did have some hip issues then, but it was mostly back and radiating pain and, some of those things. Anyway, so as she comes in the door, she's got an intelligent gait, no question about it, and is having trouble advancing her leg forward. So there's the old Tredellenberg kind of issue that you see with a little bit of a circumducted gait and a hip hiking type of action that goes on with trying to swing the right leg through. Decreased time on the right leg. As she gets going and moves around, she actually can normalize her gait pretty well.
Okay.
When she stands still and or sits for any length of time, it all goes back to the way it was before. So she can actually exercise. She's been walking 3 to 4 miles a day. She can stretch and do some movements. Interestingly enough, moving around in bed does not bother her.
And she can sleep on that side and everything, no problem?
She has no problem in bed.
Okay.
Yeah, I know, right? So this was a little bit more puzzling. So, but, so I had her just, stand as usual. We just kind of looked at the, what is it? What's happening? I asked her where she was on her feet. She could pretty much tell me that she was standing more on her left side. And she says, it feels like I actually have one leg longer than the other one. Which is interesting because, she was all pulled up on the right side, up around the right pelvis and right lumbar spine, quadratus and, back extensors and everything, working pretty hard to just hold that side off. When we did some things just to help her begin to start to shift weight onto her leg, and onto her right foot, that began to make the symptoms worse almost immediately.
Okay.
Pain in the front of the hip, pain deep inside, and every once in a while some sharp pain right in the posterior region, right in the middle of the glutes, back there where you would think the posterior wall of the pelvis is and the hip and the hip joint.
Got it.
So just trying to work on, beginning to shift weight was painful and problematic for her. So we left that for right now. I had her do a bend over. That was fine. Any kind of thing for the, for the back, side bending, extension, all of that was fine. Didn't change anything. Didn't make it better. Didn't make it worse. Nothing. The back was fine.
Okay.
And then, taking a look at her feet, she was holding her right foot pretty tight, which would make a lot of sense, but she was also holding her left foot pretty tight too. And she was standing on the lateral border of her left foot quite a bit. And she did tell me that she had some soreness along the side of her left foot more when she would walk long periods of time than she had before. So that was...
Yeah, no, so you said walking long distances and standing bothered her.
Walking long distances feel good. Once she gets going and she's moving, everything feels good.
Okay, so it bothers...
it bothers her to stand still.
Got it.
It bothers her after she's been sitting.
Got it.
And if she sits for a long time, it bothers her.
Okay, got it.
Depending upon how she's sitting, of course.
Yep.
And that's why, one of the things I asked her is I said, what about in bed? Moving in bed, messing with the covers, kicking pillows, doing those types of things, no issues.
Okay.
So anyway, we looked at the back. I had her squat. She was able to squat a little bit lower than 90 degrees, but was reluctant to go any more. And she said because it hurt in the front of her hip to go that deep. And she was also concerned that she wouldn't be able to straighten up.
Okay.
So we tried it a different couple of ways. We tried it with the legs further apart. It was easier, of course, the wider we went. Harder, the more narrow we went. And, and then she was showing me some things that she was trying to do, like standing on the left leg and abducting the right leg and swinging the right leg around. And she said sometimes that helps, sometimes it doesn't. But she feels like if she keeps it moving, it's better, which that's always better to move if you possibly can.
Yeah. What about open chain hip flexion? Could she do that without pain?
So in standing, she could lift her knee up to less than 90 degrees, but it bothered her.
Okay.
We laid down and thought, we're just going to go right after the hip here for a few minutes and just really see if what's going on here. Because it was too hard to get an idea of what was really happening in standing. Because there was so much noise with trying to weight bear and not weight bear and everything else. So laying flat, she could bend, she could get her leg up to 90, maybe even a little bit more. I could pressure her down to about 110. Sensitivity for sure in the front of the hip.
Okay.
And, she would grab the side of her hip a little bit there too and say, I feel it there as well. As we moved more into abduction with flexion, less. Less of the grabbing on the side of the hip. It felt a little bit better the more we moved into abduction and flexion. It felt worse the more we went into straight flexion and certainly towards adduction and flexion.
Got it. Okay.
Was much more painful. The Faber test was positive in the front of the hip.
Yep.
So, that was there. She barely could get past 45 degrees going down. In that cross leg position, but the biggest telling thing was putting her in knee, hip flexion at 90 and trying to do internal rotation. She had none. Zero. And whether it was joint related or muscle holding related, didn't really matter. She had none and it hurt. That really bothered her. On the other side, she has about 20 degrees of internal rotation. She's a bit retroverted on both sides. And, but, and she could, in full Faber, everything was fine on the left side. So you had a nice side to compare everything to. And, so closed packing bothered her. No point in doing a scour. I already put her in all the positions the scour would put her in and they were already painful. So why would I press on that? But what I did do is a distraction to see. And when I distracted her in the open pack position, there wasn't really much of a change. It didn't hurt. It did not hurt. It was all fine. When I put her in more of the, close to, just the leg straight and more of an adducted position, little bit of flexion, and did the distraction. At first it hurt, and then it immediately started getting better.
So she's like in a long lever, straight leg raise, you're adducting and then flexing and you're
Right,
distracted.
but adducting towards midline, not
Yeah,
across midline.
got it.
Just that position. But going into abduction didn't seem to relieve it as much as when we were in a little bit more close pack.
Got it. Okay.
And so, at first it was painful, and then immediately it started relieving the pain. And like a lot. Like
And were
that
you
was
doing a long lever distraction at the
yeah.
ankle? You are. Okay.
Yep. Just that regular thing. It's an orthopedic test to say, if they've got hip OA, it should get better with that. Well, hers did.
Yeah.
Of course, there's a bit of an inflammatory component going on here that we'll talk about in a few more minutes. But that really, really, really made her feel much better. So we did that a few times. Of course, why not, right?
Right. Mm-hmm.
And then she was able to stand up and we were able to start doing a little bit more weight bearing. So we just basically did the hands on the countertop and see if you could just lift your left heel, leaving the toes on the floor, so she could begin to shift a little bit, just shifting at her feet. I got on her foot. I let you jump into my head and got on her foot, and it kind of helped her maintain a little bit of, move into a little bit of pronation on the left. I kind of went across the bridge of her foot with my hand and just got her to move into a little bit of pronation to see what would happen when on the other side. And interestingly enough, it helped her kind of calm her right foot down a little bit, and she was able to not grip the floor as hard when she was trying to weight bear. So we decided to start working on the feet a bit and softening the feet and getting the feet to change a little bit, so that because she was just grabbing the floor really hard on both sides. And, part of that is fear-based. It hurts.
Yeah.
So of course you're going to do all of these things, your brain's going to set all that up, and, some patterns that are part of the pain experience. So interrupting the loop was pretty key there to get things to calm down. She could only do that for about 4 or 5 minutes at a time before the pain would start back up again. So we just kind of limited it to 2 minutes of work, kind of periodically throughout the day. Because she lives on a boat, we got on the stairs. I can't mimic the gangway stairs, the ones that go straight up. I mean, theirs don't go straight up, but they're pretty straight up and down. They don't have the angle to them that regular stairs that land-based humans run up and down. But we did get on there, and we got to the point, so we went to regular stairs. I had her stand on one stair and leave her right leg there and step down backwards, with the left leg. So she would be in, some hip flexion and knee flexion, but she didn't have to lift her leg up to get it there. We went the opposite way.
Great idea.
She said, going upstairs, I have to go one leg at a time.
Yep.
She said, I can do it the other way, but it hurts. So I've just been limiting myself to one leg at a time. So we did that one leg at a time, went up 2 or 3 steps, and then I had her step down.
Like that.
So she was in stride, and she could begin to kind of, do some weight shifting and stuff in that position, because that's something she could do on the boat.
Yep.
Then we tried, and we went, and I said, so I just held her, and I said, whenever you can, hold on to the railing as much as possible, but let's try to go down one more stair with the back leg. So it would put her in a lot more hip flexion. So the right leg's up high, the back leg is down 2 stairs now instead of 1.
Love it. Yep.
And she was able to kind of, so she saw that she could actually get into some hip flexion without having to have the pain that goes with it. So I was just trying to go backwards to see what I could do to help her get some more mobility in the hip joint without having the pain experience.
Yeah, that's great.
And the pain experience seemed to be coming from it's almost like when you look at somebody trying to move their shoulder and they overgrip with their upper trap, rather than moving the shoulder, the upper trap is overgripping. It was kind of one of those. As soon as she goes to flex that hip up, there's this overgripping of the lateral muscles around the torso, and it just hurts. There's suppression that's going on rather than gliding. So what I was trying to do was help to see what we could do to get some self-gliding going on in that hip.
Yeah, and have gravity do a little work.
Right, and like a posterior glide, because, the distraction in the posterior glide felt better. I forgot to mention that when we were doing this stuff on the bed. If I took her into a posterior glide with a belt, that felt good too.
Yeah.
So, so I was trying to think of some things to mimic that. And we just kept the cue at the feet, like, what are the feet doing? And, so she'd soften her feet, and that would relax her torso to where she could be a little bit more even, so she could play with that.
Mm-hmm.
And in that position, we could hike the hip up on the right side and then hike it way down, or hike the left hip up, if you will, so we could kind of move through those positions there. And she had the handrail, and I knew she could do that on her, on her, the gangway, in her boat. But if she could approach it from stepping down rather than trying to lift the leg up,
Up. Yep.
so, and then we, played with it like that. She also has a way at the back of the boat where there's 1-2 steps to get to the top of the back of the boat. I don't know the terms for boats, but the aft side, where, instead of trying to pick that leg up, to put it up there, step up with the other leg, get up, and then step back down with the left leg so she could get in that position there.
Got it.
And because that would just be a different angle. And to be able to play with some of those angles and to do with that, because what I was trying to do was help her be able to mobilize this leg without having to rely on other people to do it, and to be able to use what she actually had, in the boat to do.
Yeah, I like the all fours Shirley Sarman one, where you put that right hip in external rotation and you just sort of sit back. That's a good one too. But I like the steps.
Yeah, so she has limited space on the boat, but she can get on her bed.
Yep.
And she can get on the floor. And so we did that was the next thing I was going to say. We did do we got on all fours. And one of the things she couldn't do was, she immediately wanted to, kind of like, as people do when they get on the ground on all fours, they start moving around a little bit. And she was unable to, like, bring her leg forward, her right leg forward. That hurt. And I said, well, then don't do that. Let's just work on shifting weight onto it and see how it feels in this position to shift weight versus standing.
Yep.
So we did some, shifting of the weight over and back. And while she had her knee on the ground, just shifting her foot into internal and external rotation to see if she could gain any motion that way. It was still really hard to get internal rotation. So we just said, just kind of, in this position, bring your feet closer together, so that we were going into a little bit like you were talking about with the Sarman exercises, going into that. And then we did some shifting backwards so she could get that posterior glide, into the joint. And also, she could work her torso a little bit more there without the feet being involved. So we could get more of the same type of movement and mobility. And then I had her just go ahead and just come down onto prone and just do some cobra stretching up to see how that felt in the front of her hip. And it was interesting. It didn't bother her to do that. It didn't bother her back. It didn't bother her to do it. She did feel, she reported that I feel really stiff in the front of my hip, which makes a lot of sense to me because she's holding that hip in a lot of compression and a lot of, pulled up, on that side. So we kind of played around with that a little bit and just kind of worked on doing some side shifting, like back down to like almost, just elbow, prone on elbows. And just worked on kind of, side bending the left side of the trunk, side bending the right side of the trunk, just to kind of get the hips to shift, the pelvis to shift, I guess I should say, to try to bring in a little bit more adduction on either side. Because as she would side bend left, the pelvis would shift right. And the legs were staying where they were so that they would be adducting at the hip a little bit and just kind of with symptoms there.
Yep.
And in the beginning, she wasn't able to disassociate her trunk and pelvis. But as we kind of got going, she was able to, coordinate it to where when she first did it, everything kind of went together. Then she was able to kind of isolate and, the back would move, the pelvis would move, the hip would move. They'd all move, kind of the way that they were supposed to instead of all together as one unit. And got those going. And then the final thing I did was some monster, some TheraBand, kind of just monster poses and maybe some monster walks around her, kitchen galley, the little bit of limited area they have to walk. And as long as she stayed partially flexed, like at about 15, 20 degrees, she was able to do it somewhat. She had a real big bunch of difficulty there, and part of it is because she just isn't isolating and using the hip abductors and rotators like normal because they've been kind of offline.
Right. So is she doing monster walks backwards, forward, or backwards, sideways?
Sorry, sideways.
Sideways.
Sideways and forwards.
Sideways and forwards. She could do the forward.
So I started it forward because I thought, just naturally people can just kind of like walk forward.
Yeah.
But she was having a lot of trouble with that. So we just stopped and we said, what about just, taking a little small kind of like just chunk sideways and chunk sideways.
Yep.
And she was able to do it. But, I have to tell you, I know that it was probably good for strengthening and doing some stuff. But all it did that I could see was feed into the whole pattern of mass pattern of movement.
Yeah.
That whole disassociating thing. So I actually took her off of that. Even though my whole PT brain was saying she needs a strengthening. And it's like, but not if I'm strengthening a pattern that's really faulty for her.
Exactly. We talked about this last podcast, right?
Yeah, exactly.
Yeah. You feed into this bad motor.
I was afraid to feed into that same program. So what I did instead was I just had her start kind of thinking about and although she's already standing on her left leg, I get that. I thought we've got to get that right hip moving in some other directions, so I know the goal is, I'll get them on the other side and weight bear and do this. And it's like, but we still need to get that hip moving separately from the back and the pelvis. She was moving everything together. And I don't want the only time that to happen is when she lays down on her stomach or gets on hands and knees. That needs to happen other times of the day too.
Got it.
So I asked her, I said, I know that you're kind of like doing this whole limp thing when you walk. What would happen if you just let your toes drag on the floor on the right side? So she advances. And so we did that. And it was interesting because she was able to easier slide her leg forward. And I said,
course, yeah.
Can you play around with that just a little bit, at different times of the day? And, just kind of let your foot slide forward. And so then she started saying, well, what happens if I just kind of stand on this one leg and I kind of like circle around and stuff? And I said, well, because she was trying to lift her leg up and circle it around, and you can imagine what was happening. The whole trunk was lifting and everything. And I said, well, what if you put your foot back on the ground? And, but what I did was I got over on her left foot and kind of helped guide it towards pronation again. Just that little shift with my hand towards her, on her midfoot towards, kind of in that direction towards pronation at the midfoot.
Yep. Right. Yep.
And I said, let's concentrate on this foot while you're moving the other foot around on the ground.
Yeah, I like that.
Because our tendency was to still pull off onto the lateral border of that left foot and stay really shifted farther over. And it's like, you can change that a little bit. And so what we did was we just did some circles on the floor, like I said, and she would get to a point to go, it hurts right there. And I said, well, then just come back a little bit, like make a cut in the circle, like put a wedge in the circle that takes you, so you don't make a full half circle. You have kind of a little wedgie in there, and then you come back around. And just kind of explore, that motion just a little bit. And I said, see if you can find ways that you can move without it hurting.
Yeah, if you think about when you're standing and you're putting all the weight on the lateral border of your foot, it's pulling that on the left side, it's pulling that right side into internal and internal rotation a little bit and adduction, which is compressing our hip to begin with.
Right.
Compressed hip.
Right. Exactly, which is why I abandoned the monster walks, because even though she was in inflection and abduction, the mass pattern of movement, it was just, she couldn't do it. She couldn't do it without the TheraBand.
Yeah.
So I took the TheraBand off and did it without the TheraBand. She still couldn't. It just it wasn't going to work.
Too hard.
And it just looked wrong to me. It just like, this isn't going to solve the problem. This is going to feed into the one that she already has. So I thought that was interesting, though, going down to the feet and really, especially on the opposite foot. Because it just seemed to change some things to where she just was able to let that right side go when that left foot wasn't holding so tight.
Right. Because when you think about it, you're going to offload that painful side anyway, and she's been doing that for some time, and she can compensate. But after a while, you just run out of options to compensate, and you can't keep doing the same thing over and over again and expect to feel good unless it's the same faulty movement pattern. And just facilitating a little bit more of that fanning, that pronation in that midfoot will cause that subtle shift back onto that right side. And it's very subtle, right? These aren't like big changes, but they're big changes for the patient, because their nervous system says, oh, I can sort of get my right leg on it. I can get on my right side without actually activating the muscles on the right side, on my right hip or my right lower leg. Just by fanning that left midfoot caused her to shift subtly over, which was great. That's fantastic.
So the final thing we were left with. So I was pleased with how that went, and we were able to come up with some movement patterns and things. And I asked her, to go back and to, talk about, to think about how long she was sitting and how it felt when she got up, like, if it happened almost immediately after she sat, or, or what went on. And she came back the following, because like I said, I had her for a couple of days, and she came back the following day and said, it happens immediately, even if I sit to go to the bathroom.
Mm.
When I come back up, I'm back in the same thing. And so that was interesting to hear, because I said, well, what would happen if you did some of those things that we did yesterday as soon as you stand up? So,
Mm-hmm.
she went, and so we practiced that a little bit. We sat in the chair for about 2 minutes, 3 minutes, 4 minutes. Then we'd stand up, and, the whole pattern of movement would come in where, the guarding and the holding and
Mm-hmm.
everything. And so number one was change the foot. I hate to use the word relax the foot, but I just said change the foot to where you're not on that outside of it so much. So she could actively start to shift on that foot better now after
Mm-hmm.
giving her the cues and stuff. But I'm not going home with her. She has to have a way to cue herself. And then I said, just explore the movement on the other side and let's see what's going on. And remember, only go through ranges that feel okay. And it made it easier for her to kind of walk after that. It wasn't perfect. It wasn't, tremendous, but at least it got her out of that pattern of movement and was able to change it immediately rather than having to wait until she could walk, 2 miles to get that to feel better. I
Right.
wanted her to have ways to feel better, right away
Quickly.
after standing up, after laying down, those first thing in the morning, first times out of the chairs, those types of things, so that, because what I would notice is that, she just kept doing everything the same way, even if she had a different way to do it. So then it kind of became more, let's pick these times, so that if we can be consistent about it, perhaps this will change the motor pattern enough that, things will start to reveal itself differently, or what, I don't know. I said, let's just see what happens. That's the
Yeah.
best I can do. And, this has been a long-standing problem now for some time. And, everything else is cleared up, but this is, this is where we are.
Yep.
So she wanted to know if she should get it imaged. And, I said that, I, I said, sure. I mean, I don't think it's going to show you anything that you don't already know. I said, but there's really not going to be a ton anybody's going to do anything. They'll just say to you, you'll tell me when you want something done,
Right.
and she's not having pain at night. She's
Yeah.
sleeping fine,
Yeah.
so,
Yeah.
which brought up the other piece that I wanted to talk about a little bit. I did talk to her a little bit about her diet and the anti-inflammatory diet. And I said, there's been some great stuff and about that, and it can really help the situation quite a bit. It's not going to change any joint changes that you have, but people live with joint changes and do okay. So I don't know,
Mhm.
maybe if you, kind of looked at it from attacking it, through, the GI system a little bit too. So I gave her
Mhm.
some information on anti-inflammatory diet. Joe Tata's book is really good
Yeah. Yeah.
on that, and I gave her that reference, and I said, just read the stuff. I said the biggest culprits out there are going to be things like dairy, sugar, and then to some extent soy, corn, and wheat, But I said, there's big ones out there. You can just kind of back off of them and just eat a little bit more clean and see how that
Yeah.
goes. And
Yeah.
I think Diane Lee has a lot to say on the matter herself
Yeah.
with everything that she's been through,
Yeah. With her hip.
and
Yeah.
how her her diet made a big difference in her inflammatory response as well, and it certainly has in mine and other people that I know. But anyway, so we I wanted to be sure that I kind of snuck that in there, but I'm not sure. I don't see a lot of people with really, really closed pack hot joints like this one.
Yeah.
So I was interested in some of your experiences in this as well, and other things that you've noticed or pearls of wisdom you may have along these lines too.
Yeah. Well, a couple things. You know, I have two stories. One is that I had a patient some years ago now. She was probably in her 40s. She had horrible hip pain, and she'd been everywhere and didn't know why she had this hip pain. They have, she had an x-ray, she has horrible hip arthritis, and she's like, I'm 42. How could I possibly have that? And in her history, she had a laminectomy, many, like I would say when she was a kid, because of foot drop.
Mm-hmm.
And as we're standing there, she's like, whenever I stand, my sock falls down. And I'm like, well, you did have foot drop. So we went through the whole process, and it turns out in order to clear her foot from the floor, she kept hiking her hip up for like 25 years
Mm-hmm.
and gave herself an arthritic hip. When I tell you, Susan, this girl had her hip was resting in external rotation. She had
Mm.
like when I want to say like minus 40, I mean she couldn't even get to neutral. I mean, I had her
Mm-hmm.
prone. I couldn't even get her into
Yeah.
neutral. That's how bad this girl's hip was. And she got better, but she did end up having a partial hip replacement because of her age.
Mm-hmm.
And it was so far gone at that point. And she has a family history. And now, and she's doing well now, but I recently had a similar situation to yours, but this person is young,
Mm-hmm.
and he's had a lot of bad hip issues for many years now, and they never really got better. And he had the same thing: deep squats, deadlifts, open chain hip flexion, and he, I think, did have an X-ray, which didn't really find anything. He's young.
Mm-hmm.
But what helped him a lot was, I mean, I won't go into his whole thing. We should talk about him at some point. He actually was partly of a thorax driver. However, he did have a partial hip secondary issue. So what I had him do, which I like the backward stairs because he had issues with stairs, I had him lie on his back, put his feet up against the wall like in a tabletop, and had the gravity, like do some bent knee raises, just let gravity assist him into hip flexion, and had him do some bent knee fallouts, which didn't bother him at all. And he also had a
Mm-hmm.
problem squatting below 90.
Yeah.
And
Yeah.
so when he started doing those trick moves, like, like you
Mm-hmm.
did with the stairs, and then the moves against the wall, he told me he felt immediate relief because we're going in the back door with these things, right?
Yeah. Yeah.
So that I think is
Yeah.
key.
The hip fallouts are a good idea too.
Yeah, so
Doing
the,
those.
I,
Mm-hmm.
right, I think that is key because these people have developed these non-optimal movement patterns overusing adductor, rectus, pectineus, whatever you name it.
Mm-hmm.
They've done it, and to just anything to turn those muscles off, backward stairs, the tabletop against the wall, the bent knee range, I think is
Mm-hmm.
a really nice way of doing that because they need to turn those muscles off.
Mm-hmm.
I have a question for you. Did you ever think at any point that she would have like medial, if she had some medial compression, do you ever think, did it ever cross your mind to go internal and check for obturator internus? I mean, this is my non-pelvic floor background asking, but did that ever cross your mind at all?
Well, I asked a series of questions. There's no urgency frequency. There is no pain with sex. There is no, other than sometimes the hip itself. They had to be careful about positioning.
Yep.
But no pain with penetration.
Okay.
Nothing that would lead me down that path. I did do some hold relax to see
Mm-hmm.
if I could gain, to see how much of this was a muscular component holding.
Yep.
That I didn't mention before, when I did the Faber's test and, the range of motion and the stuff on the hip, I did do a series of hold relaxes and things to see if I could get the hip, external rotators or internal rotators to stop over gripping and see if we could gain some internal rotation.
Mm-hmm.
And just that solid infill. Now, I
Yeah.
didn't have her long enough to do more work. I'm not sure if I would have found a painful obturator internus or not.
Mm-hmm.
She certainly, she didn't really have a lot of pain on the external muscles pressing around. I mean, she has some sore spots, but nothing that were like, you know,
Yeah.
yeah, so, but I always think along those lines, and I just really, there wasn't really anything that led me to think that, oh, we've got some pelvic floor muscles that
Yeah.
are really
Yeah.
over gripping and overworking here. I'm sure that her obturatus is probably over gripping. But
Right.
so are some of the other muscles that are trying to pull her into a little bit of external rotation.
Yeah.
I think the biggest overgripper that she had, quite frankly, when trying to flex her hip was her TFL.
Yeah. Yeah, it's a
You
big
know,
one.
she was really overworking the TFL. And again, she was doing a lot of, that trunk,
Hmm.
lifting the whole pelvis up to try to help that hip,
Yeah. Yeah.
slide forward.
Yeah. I think with the hip arthritis, obviously, you know, these people you've treated her before, excuse me, and you know, when people who have significant hip OA and like my patient earlier, the 45 years, her function was so poor at that point. She couldn't play with her children. She had
Yeah.
developed so many bad patterns of movement that it was a relief for her to get that operation. And she did have
Hmm.
a partial. So, but with other people, a lot of times, because if they're functioning fairly okay, but there's certain hip things that bother them. I mean, I don't particularly like, when people say, "Oh, I've got, bone on bone in my hip," and I'm
Right.
like, it's not really helpful language, and
Right.
that's another podcast.
Hmm.
But ultimately, it's their strategies and it's their gripping. They're using non-optimal, whether they have a hip replacement or not. If they're going to use the same strategy pre-op, they're going to use the same strategy post-op. So
Exactly.
you need to change that, whatever they're going to have or not have. And I think
Hmm.
people are surprised that when you start changing patterns of movement, it, and gaining a little bit more range through the back door and changing the context of
Hmm.
movement, they actually feel better. And
Right.
I really think it's important, especially with hip OA, to change the context because that open chain hip flexion and even just weight bearing is so painful. And I love the foot. I love, put the ball under the bottom of the foot, release the feet, do that type of thing. And when she's stepping, I remember at CSM last year, I think we've talked about this before, intrinsic versus extrinsic cueing.
Hmm.
Um, I forgot maybe it was Chris Powers, one of his lectures. Anyway, he talked about how, you know, straighten your feet or drop your arch. You want to do more intrinsic or extrinsic. I don't
Hmm.
remember the exact one, but it's more like feel your feet rooted to the ground,
Yeah.
relax, that whatever.
Stretch
More
your toes towards the wall. Yeah. Things
exactly
like
to
that.
take them
Hmm.
away from thinking about the body part, more of like
Hmm.
using more imagery,
Hmm.
which Eric Franklin does fantastic, right?
Yeah.
So things like that. And I think when you have the hip and the feet, I believe, I mean, are very much related. And if someone has a problem in their hip when they're walking, you got to look at their foot. You have to.
Hmm.
You have to.
Yep. So anyway, we've left it. She has her things to work on. She's going to check back with me in a month, and see kind of how it's going and what her barriers are to consistency and things like that. She probably won't be able to get any imaging done till late in the spring because of, by the time you get authorization and all of that, and they have to dial that back in when they're back landside, to have
Mm,
something like that done. So we have a window of time here. She certainly wants to do everything she can to gain as much mobility as possible and decrease her symptoms,
yeah.
as much as possible. So she's motivated and in to do it. So we'll just see how it goes.
Yeah. That's
All
awesome.
right.
Cool. Thanks,
So
everybody.
thank you, everybody. Thanks for listening. We look forward to your comments. And as always, go in and rate us on iTunes, give us a review, let us
Yes.
hear from you through email and social media, any other way. Erica, you want to talk a little bit about the mastermind and that's coming up quickly in February?
Yes. So we're at CSM. We're hosting a 1 day mastermind, like 7, 8 hours, on the Wednesday before. So it's February 12th. And if you're on our email list, I've put out the link to the lead page that has all the registration information. So it'll be February 12th, the 1 day before the start of CSM. And if anybody has any questions or inquiries, just email or reach out to us on social media. It's going to be great because it's bring your practice challenges. We'll talk about tough patients. We're still devising the setup, but whatever you guys want to talk about, we can certainly do, or we can sort of present whatever. It's pretty open right now. In addition, we're going to be recording probably 2 or 3 live podcasts from CSM, and we would love to have our listeners on the podcast. So if you will be at CSM and want to be on our podcast, you can bring a tough patient that you're having a difficult time with, or if you just have general questions about what we talk about, or any clinical pearls that you want to discuss, we would love for you to be our guest on the podcast. So email either myself, Eric at ericamello.com, or Susan at embody-pt.com, or reach out to us on Facebook. For me would be better, any form of social media, and we would love to have you on the podcast. So if you're listening to this live when this gets released, email, and if you're on our email list, just email back and say, I want to be on the podcast. We'll take the first 5 people. Okay?
Sounds awesome. Looking
Awesome.
forward to it.
You too.
Okay.
Bye.
Bye, everybody. See you next time.